Well, good afternoon, everyone, and welcome to today's webinar, Opioids, Diabetes Drugs, and Anticoagulants, Interventions and Best Practices. My name is Laurie Fink, and I'm the Communications Specialist for the Improving Care Coordination and Medication Safety Initiative. We will get started with today's program in just a few moments, but first, a few housekeeping items. All participants entered today's webinar in a listen-only mode. Should you have a question during today's presentation, we ask that you please type it into either the chat or the Q&A box to the right of your screen. We will answer as many questions as we can at the end of the program as time permits. Today's webinar is being recorded. The recording and the slides you see today will be posted on My Quality Insights in the Care Coordination and Medication Safety section. I will now hand over the presentation to Nicole Brandywine, who is the Adverse Drug Events Network Task Lead for Quality Insights. Nicole?
Thanks, Laurie, and thank you to everyone for being here today. We have a great program ahead, so let's get going. Michael Kleinschmidt, PharmD, is a graduate of the Philadelphia College of Pharmacy and a board-certified pharmacotherapy specialist. He's currently the Director of Pharmacy at Brandywine Hospital in Coatesville, Pennsylvania. During his tenure as a pharmacist, Michael has worked in a variety of arenas, from the emergency department to general medicine to neurotrauma. For the last 2 years, he has been in management positions within the hospital pharmacy field. He believes that pharmacists have an opportunity to change healthcare models through their outstanding clinical, practical, and prospective ideology. Pharmacists can help to better serve patients, and this responsibility should not be taken lightly. And now I would like to turn the floor over to Dr. Kleinschmidt to discuss an opioid intervention.
Thank you, Nicole. I appreciate that introduction. Everybody hear me all right? All right. I will be sharing my screen today so you can see it. I wanted to say thank you to Quality Insights for the opportunity to speak to you today on what I consider a very important topic, opioid abuse within the community. I have nothing to disclose. I did realize, and going through my slides briefly before the presentation, that I did not have my email up here. I will post that in the Q&A section shortly thereafter. I was told I have 13 minutes to do this, so I'm highly caffeinated, and let's get to it. So I'm here to talk to you a little bit about our hospital pharmacy and what we've done, which could be used as a microcosm to discuss opioid management in the community. So I want to start with a simple question, and we'll make these rhetorical questions so not everybody's jumping in. We'll start with the question, what is pain? There's a million definitions of pain, but if you were to look it up in Webster's, it says the physical feeling caused by disease, injury, or something that hurts the body. Pretty basic, but it's a subjective decision. It's a subjective pain. So what we feel is what we feel, so everyone can define it differently. And this is important. I actually just gave an intro to our new hire nurses here at Brandywine today to talk about the goal of pain management. What is the goal of pain treatment? Well, I gave it to you. I cheated. It's management. When we ask patients if they're in pain, we typically will say 1 to 10. We don't say 0. The goal is not to make pain go away. It's to manage the pain. Everyone can handle a certain level of pain, and it's inherent upon us as healthcare professionals to make sure that we can go ahead and work with our patients to make sure we're at a level that works for them, not to make it go away. So a couple things I'm going to go over real quick today. A little bit of background on the opioid epidemic with a little bit of focus in Pennsylvania, because we're in Pennsylvania, I'm in Pennsylvania, so I'm going to talk a little bit about that. Kind of the breakdown of hospital pharmacy, how it's changed, and what we could do to change the culture, not just in a hospital, but out in the community, which is the purpose of this discussion. A little background on the opioid epidemic. Opioids, as we all know, are incredibly important in pain management. However, the past decade has seen a huge increase in the amount of them. But when used appropriately, opioids are a viable and reliable strategy for pain management. The word appropriately is underlined. If you go to get a tooth pulled, I don't know that you're going to need to leave with a prescription for 180 of OxyContin 80s. Maybe it hurts a lot, but it doesn't hurt that much. So when used appropriately, opioids represent an effective treatment strategy. With that being said, we'll break it down a little bit as to what happens here in Pennsylvania. No, this is not the election map from 2016. Regardless of what side you went for, this is it's just a blue background of the counties within Pennsylvania. So actually, I believe Pennsylvania went red for 2016. But with that being said, a couple sobering statistics to kind of talk about here. Within Pennsylvania in 2014, there were 2,500 overdose deaths. 2,500. That's higher than the national average. But everyone listening to this call can agree that their counties, their communities, one is too many. So to break that down and expand a little further, that's 7 deaths a day here in Pennsylvania. That's 1 every 3.5 hours. I've been here since 7 o'clock this morning, so effectively 2 people. That's 2 people. That's pretty sobering. Typically when I give this discussion, it's to a room full of about 50 people. And when I get to this slide, I ask everybody to stand up. They all look left, right. They see everybody standing up around the room. And in theory, at the end of the week, everybody would be gone if that represented the number of opioid deaths within Pennsylvania. That really hits home for a lot of people. I've been told that that's a great kind of home run for them to see what and how pervasive the problem actually is. So to break it down a little bit more, I think percentages are nice, but I think numbers actually really take it home. So again, this is with Pennsylvania. 64%, 36% were female. The 64% is about 1,500 people, and then 1,000 females. That's, again, a very sobering statistic. And you can see the breakdown here a little bit more. I won't get into all the individual demographics, but there's too many. There are way too many. To look at it, there's not one category. There's not one race, age, sex that has it more than others. It's really across the board. And that's the misconception a lot of times when we talk about the opioid epidemic. Everybody thinks you have that image of somebody in a dimly lit building in an inner city with the heroin needle. That's not who it is. A lot of times it's the kids trying it for the first time. They found them in mom and dad's pill closet, and you can kind of see that in this graph. It's a pretty sobering statistic, and when you see it in graphical form, it really, really shows that it's a very pervasive problem. Heroin and opioid are now the leading cause of accidental death in Pennsylvania. That's shocking. And this has not gone unnoticed with the government leaders here in Pennsylvania. So I won't go through all their quotes. They'll be in the slides for you to read later. But the first one's from our governor. He recognizes that this is a problem. He's actually had special meetings, councils out in our state capitol in Harrisburg to discuss the issue and what to do moving forward. They've actually appointed a czar to work through the problem and come up with some of the solutions. Here you have some of our state reps and state senators who have also commented on the issue. So it does not go unrecognized. With this being election season, this was actually one of the bigger discussion points in the local area for re-election for a lot of these guys. So the FDA, sometimes the things that they put out are not the easiest. They actually formulated a pretty simple game plan for this. Reduce the impact of opioid abuse on American families and communities. Fairly simple, but then the question comes into play, how do we do this? This is that plan a little bit more in depth. I won't read each one to you, but they're common sense things. A lot of these are just things that we should do without thinking about it. We need to look into the opioid problem more. We need to look into the medications and do what we can to reduce the impact. And that's kind of the take home. If you take nothing home from this presentation, please take home that we can all do something. And what that something is, well, mine's different than yours. And that's not a bad thing. Everybody can do something to help the issue. This is our congressman here, one of them from actually this district, and this was, I'd say, the second biggest thing that he ran on his campaign was the opioid problem. This is a quote he had discussing the epidemic. So where do we start? I can offer you what we did here at Brandywine Hospital as a microcosm. So Brandywine Hospital, we're a 168-bed hospital. We have affiliations with Temple Hospital, Premier Orthopedics, and we have a nationally renowned eating center here at Brandywine where a lot of different patients come from across the country to get services. So what we've done here at Little Brandywine doesn't always work where you are. However, you can use it as a starting point and say, these guys were able to do it. What can we do to affect our area? So when I came to Brandywine Hospital in September of 2014, I found a pharmacy and an institution that wanted to change and progress clinically. The pharmacists originally were sitting around a table and they were waiting for faxed orders. Well, those days are gone with the advent of computer physician order entry, or CPOE. It now takes, we used to take 8 hours, takes about 15 minutes for us to work through orders and verify them. With that being said, we have about 7 hours a day to go out, work with the staff and the patients, and be decentralized, working on the units, working with our patients and their families. So what do we do when we're out there? We do a lot of things. But one thing that we do, and I'm very proud of, is that we speak to every patient that comes here within 24 hours. They all get one of these brochures. Inside of this is information about how to be involved with your own care. And before we leave, we always check with the patient what their pain is, 1 to 10. So we're trying a proactive approach instead of a reactive approach to pain management. So if something's ordered, we'll go ahead and make sure that order is facilitated and delivered to the patient. Every day when we're out in the units, we perform a complete profile review. So we're looking at everything inside of the chart. And not all pharmacists have the same clinical training, so we do rely a little bit on some computer software, which I'll demonstrate to you. But every day we are reviewing the patient's charts. And patients who are actually educated from a pharmacist compared to a nurse, we actually were able to demonstrate through a trial here at Brandywine a 16% increase in communication about medications HCAP scores. So it is working when we're out there. This is that software I was talking about a little bit. It's called Century 7. And the things that we have flagged immediately for our patients are all listed here for you. So anybody who has around-the-clock pain management ordered, opioids, and anyone over 60, anybody with a PCA, which is one of those pumps that you hit when you're in pain after surgery, or anybody older than 60 with 2 or more sedative meds, those are our falls risk assessments. So this is kind of what Century 7 looks like. We open it up for John Doe, and we go through every patient every day. It will flag the pertinent rule matches on there, and from there we will click into it, see why they were flagged, and work our way through the process. So if the pain meds are not appropriate, the dose is too much, we'll go ahead and we'll contact a physician and make that recommendation and document it inside of our EMR. Every patient that has around-the-clock pain management, we call. It's 90% of the time they just ordered it and forgot to check the as needed or the PRN section of the order set. So we make that recommendation. And most doctors say, thank you for letting me know. We can go ahead and put that as needed. So the difference between as needed and scheduled is that as needed, they're not always getting it. Scheduled, the nurse has to give it or else they'll get a red box in their EMR scores, and that's not always good. So making it an option for the patient to have pain management does 2 things. 1, prevents them from being excessively sedated, and 2, lets them feel involved and invested in their care. Since we've done this, actually a lot of physicians have switched to order sets that are non-opioid based for pain medication. That's awesome. That's fantastic. But that started because we made them aware of the situation of what we could do moving forward. Instead of giving somebody Percocet, you could give them a combination of Tylenol and ibuprofen instead for a pain of 1 to 3. Totally viable. And they've actually worked very well with us over the last 6 months for this. A couple good things for the hospital. We've been able to remove some of the medications that have addictive side effects from the formulary. We've actually been able to cut a lot of the narcotics that we have in-house. So overhead has actually gone down as well. I'm a big believer, and we can learn from the past. And Socrates once said, the secret of change is to focus all of your energy not on fighting the old, but on building the new. This is 100% applicable to the opioid epidemic going across, not just here in Pennsylvania, but across the country. So my goal for opioid management, I think all members of the healthcare team can take responsibility for our current crisis and take the time to utilize best practice techniques to better serve our patients and our communities. It's not, what we do here won't work for you. It's inherent upon everybody to do everything they can to limit this and use the appropriate dosing inside of the communities. Again, Brandywine Hospital is not 100% applicable across the country. However, the practice of identifying an issue, working with the stakeholders to improve it, and refining it to a product that you'd be proud of later and is effective, everybody can do that. So Teddy Roosevelt once said, nothing worth having was ever achieved without effort. It won't be easy, but we can absolutely mitigate the opioid epidemic moving forward. And that's my presentation for you guys, so thank you. I appreciate it.
Thank you so much, Dr. Kleinschmidt. And I just wanted to comment before we move on that even though you gave some really sobering statistics for the state of Pennsylvania and quotes from local leadership, I think all of us on the line can agree that we could very easily punch in the statistics for my home state of New Jersey or West Virginia or Louisiana, Delaware, all the other states we have on the line, and see a very similar picture. So while your information was specific while the statistics were specific to your experience, I think it really does apply to everybody, and we thank you so much for presenting it in that way. And moving on to our next segment, we will be hearing from Dr. Dustyn Williams, MD. Dr. Williams is here today as CEO of Dose Doctor, an application-based diabetes management tool currently being used by patients and healthcare providers in Louisiana, Mississippi, California, and Pennsylvania. Dr. Williams has an undergraduate degree from Yale and received his medical degree in 2011 from Tulane University School of Medicine. He is board certified in internal medicine, works as a hospitalist at Baton Rouge General in Louisiana, and provides curriculum development for the hospital's medical residency program. He also serves as adjunct faculty to his alma mater, serving as clerkship director to one of their satellite campuses. He is also the founder of Online Med Ed, an online learning platform for third-year medical students preparing for licensing exams. So with that, I'm going to say take it away to Dr. Williams.
Thank you, Nicole. Sometimes I sleep too. I am the Chief Medical Officer here at Dustyn, and I do want to disclose up front, this is my company. I founded it, and it is a for-profit company, but what I do right now is I provide medical services for free and for any patient who signs up to the app, as long as they're in a state in which I practice. So I do want people to know that this is a for-profit company, even though we're giving away medical care for free. Dustyn, as Nicole mentioned, is a telehealth platform that is designed to manage chronic care diseases. We're starting with diabetes, and that's what I want to talk to you guys about today. Now, I think everyone in this room probably knows this stuff, but I say it anyway because I don't want to leave anyone behind. Diabetes is all about blood sugar, and we want to control the blood sugar to prevent all the problems it causes. We use the A1C, a lab test, in order to determine how well we're doing. Goal is less than 7%. Most diabetes, simple diabetes, can be treated with pills, diet, and exercise. But it's the most severe forms of diabetes, those type 2s who have progressed to needing insulin, or the type 1s who have no endogenous insulin, where insulin is required. And it's often where insulin is required are the most severe. And this is why I started this in the first place. Someone who has control of their diabetes, an A1C less than 7%, costs about $5,000 per year on average. Someone who is out of control, an A1C greater than 9%, costs about $15,000 per year. And that cost, clicking malfunction, sorry, it comes in this breakdown. $320 billion were spent on healthcare costs in 2015, $140 billion of them on preventable hospitalizations and complications. If we just were able to control the blood sugar, last year the country would have saved $140 billion with a B dollars. 1/5 of all healthcare dollars is spent on diabetes, but only 9 million humans inject insulin every day. The idea is there's a very small number of people who cost an extraordinary amount of money. But it's not just the amount of money they cost. Diabetes ruins people's lives. Takes your kidneys, your eyes, your limbs, and your life. Increased risk for amputation, death, heart attack, stroke, dialysis. Again, if we control the diabetes, this doesn't happen. And this is the problem I think we're trying to solve with Dustyn, and why we started with diabetes. Diabetes is really hard. A person may check their sugar and inject insulin up to 5 times per day, and how much they give changes based on the time of day, what they've eaten, how much exercise, what their sugar is right now. And if you hand this something to somebody who doesn't have necessarily a great education, or even to some doctors, they don't really understand how this works. So it's really hard. And if you ask a patient then with even less education to try to do it themselves, they usually do it wrong. And further, there's very limited access to help. On average, a patient spends about 2 hours per year with their providers, going 3 months between visits. That's 3 months when they're on their own, left to decide how much insulin do I give right now, every time they eat or every time they inject insulin. And here's the big problem. Too much insulin causes hypoglycemia, which can kill them right then. It's hard. They don't have help. And even the providers have trouble managing diabetes, so people fear increasing the insulin dose despite lack of adequate control. That's what we're solving with Dustyn. Dustyn is 3 parts. The first is a mobile app that the patient uses to track their sugar and log injections, designed to be very simple. They do what they normally do. They have their meter, they have their insulin, and now they have their phone. They prick their finger, they check their sugar, the meter gives them a number. They enter the number into the app tells them how much insulin to give, they give that much insulin and say they did it. While they do that, as they enter that data, it is exported to the cloud. The web portal is the second piece. Providers use the web portal, available on any browser, any device, to track those changes and make dose adjustments. And in those states where we have licensure, there's actually a person as part of the platform, a dose doctor who does the medicine. And this is what separates Dose Doctor from every other diabetes app out there. We don't just aggregate the data and show it to you. We actually do the medicine. Two major problems we're solving: orange box on the top, blue box on the bottom. Orange box on top. The mobile app improves adherence by simplifying instructions. Those people who are familiar with diabetes management, correctional insulin, also called sliding scale, carb counting, variable insulin dosing, all the different types of insulins there are. Asking a patient to know that their scheduled dose is X and they need to add Y based on Z number of glucose is above the number A is very complicated. And we've come up with very elegant solutions on paper, but they still need to look things up in the table and add things together, and that's really hard. The app, enter glucose, get insulin. All of that stuff is happening in the background, but it makes it very easy and concrete for a patient to give themselves the right amount of insulin based on their physician's instructions, because it's displayed in an easy to understand mechanism. And it has support for what happens when your sugar is too low or too high. Second piece is titration. Because we have access to their information on a regular basis, we make very small titrations in the insulin dose every 3 days rather than every 3 months, which means that because we're making small changes, their sugars don't really change all that much, so we avoid hypoglycemia, but because they're frequent, we get people to goal much faster than they would have otherwise. Dose Doctor works with any insulin strategy and any glucometer. They manually enter their sugar into the app, which means it doesn't matter what glucometer they have. A provider can write whatever insulin strategy they want, regardless of how ridiculous it is. A provider can import their prescription into Dose Doctor, and the Dose Doctor will communicate those instructions to the patient. It's simple for the patient. Enter glucose, get insulin. This is better also for health systems and insurance companies because there aren't any prior auths, right? If the person signs up and you've got a formulary, the person is put on the formulary, which saves a lot of money by being on the right insulin and the right brand. And more for the patients, there's a doctor on call. We communicate with patients via cell phone, email, text, and so there's always someone available if someone has trouble, and to date, no one has abused that. Dose Doctor works. This is our pilot. We did this over the past year. 103 patients. I begged and pleaded clinics. They gave me their worst, the people who could not be helped across Louisiana. The initial average blood glucose as they entered it into our app was 232. After 1 month of Dose Doctor, the average was 133. Now, this isn't a direct correlate, but if you use those pre-meal sugars as an estimate for the A1C, we moved them from 9.6 to 6.4. And all of the patients who have stayed with us have maintained this. We had one episode of symptomatic hypoglycemia. Person gave insulin and didn't eat. I instructed her that she should not do that. 2 patients failed to achieve goal. They were on over 200 units apiece and were referred to an endocrinologist. Just to reiterate, we did that. Now, we don't actually know how much money we saved. We definitely achieved the A1C of 9 to the A1C of less than 7. So who can use Dose Doctor? Literally anyone who injects insulin and has a smartphone or a tablet. You must have an Android operating system or an iOS operating system for the app to run. I'd like to share these cases. This is a patient that I had taken care of in the hospital at Baton Rouge General. Came in with a stroke at 52. He would not get a smartphone, loved a flip phone. He left the hospital with a blood sugar of 350. Over 2 weeks, we got his pre-meal sugars on average between 150 and 200. All of his pre-meals now are between 80 and 120. After 3 weeks of his wife entering his blood sugars and insulins into her phone, he went and bought an iPhone. Dude never had a smartphone, bought the iPhone because this works so well. Behavioral change. This is a patient that I worked with, Marie Simpson, who's on the call also. This woman was in the ER twice before starting, and within 2 weeks. Once she was admitted for OBS, once she was discharged for hyperglycemia. She started at over 450, and she had this sliding scale, which were an increments of 5. I doubt that was what the doctor prescribed, but that's what she thought she had. She was actually symptomatic at 150, so we had to keep her around 200. Now, all of her pre-meals are between 100 and 150. She has not been back to the hospital. And this was our first patient. Again, one of mine. One of my residence clinics were taking care of this woman. She got on Dose Doctor, got control in 4 weeks, but suddenly went out of control. Texted her, found out what was up, sent her to clinic, was diagnosed with C. diff, treated with oral medications. 1 week more, she would have been in the ICU. For the sake of time, I am not going to be able to show you what this looks like, but I'm happy to come back and show anyone later. Instead, what I want to talk about is how the people on this call can take advantage of Dose Doctor. Dose Doctor is designed to be a concierge service in which the states in which I'm licensed, Louisiana, Mississippi, Alabama, Pennsylvania, California, but it is also a platform that your providers can use as well. We have 2 major modes, which I'd like to get involved with across the country, and especially in the states in which I'm licensed. One is readmission reduction. Reduce bounce backs by giving Dose Doctor to diabetics who reject insulin as part of their discharge planning. You identify the patients as high risk, we get them enrolled, I contact them, we work together to see what happens. Ideally, A1C will be better controlled and bounce backs will be reduced. The second is outpatient, improving quality metrics in the clinics by getting the A1C down. Again, identify high-risk patients, use case management or physician selection to get patients onto the app. By signing up to the app, they effectively are referred to me to take care of their insulin. Dose Doctor, chronic care management, talking about diabetes here. My email is dustyn@dosedoctor.com. My mother gifted me with a Y in my name, D-U-S-T-Y-N, great icebreaker, really frustrating for everything else. And my cell phone, 415-444-6370. Anyone who's interested in doing a project with us, we welcome. It doesn't matter what state you're in, we can try to figure something out. Thank you very much. That's Dose Doctor.
Thank you so much, Dr. Williams. That was very informative. And I just want to a little caveat to say that, here at Quality Insights, we do not promote any particular smartphone of any kind. We're not responsible for the promotion that Dr. Williams gave. Just kidding. But in all seriousness, thank you very much for that presentation. And we do have on the line, actually, if I'm not mistaken, a care coordination nurse that is actually a user of the application with patients that she is working with in her home state of Louisiana, and she will also be available during the Q&A to comment from the user's perspective or from the nurse's perspective on this in action. And there are other web-based or application-based things out there, and we greatly appreciate the opportunity to learn about them.